Hi everyone, and welcome to our module on delirium and dementia. So dementia and delirium are both conditions where people get confused, but they're distinctly different pathologically and in the way they present, and you need to be able to tell them apart. So dementia is a chronic confusion. It's usually a progressive, slowly progressive cognitive decline, and it's usually due to an irreversible underlying pathologic process. Delirium, on the other hand, is acute confusion, so you can get acutely delirious with a high fever, for example. It often has a waxing and waning pattern where people will be more oriented for a period of time and then more confused, and this will change over the course of hours. And delirium is usually due to some type of reversible cause, like the fever I mentioned. That delirium will get better when the fever goes away. So let's talk about delirium in a little more detail. And remember, this is an acute onset of confusion. So patients who are delirious can't focus and pay attention. Their thinking is very disorganized. They sometimes have hallucinations, often visual, and this is less common in dementia. And their sleep-wake cycle is disturbed, so a delirious person is often up and agitated at night and may be somnolent during the day. So delirium is usually secondary to another cause, often a medical condition or a drug. So infection can make people delirious. Drinking alcohol can make people delirious. Patients who are withdrawing from alcohol or opiates will be delirious. And then the most common cause, and something that you're definitely going to see on clinical rotations, is dementia patients who are in an unknown setting. So demented patients orient themselves by getting familiar with their surroundings. So when they're at home, they recognize where they are, and this keeps them calm and oriented. But if you take that demented patient out of their home and put them in an unfamiliar hospital surrounding, they will suddenly become delirious. So for example, a patient who has baseline dementia and develops pneumonia and gets hospitalized will often get delirious. It's because they're in an unknown setting and also because they have an infection. And this is the most common reason for altered mental status in the hospital. It's a demented patient who is now sick and out of their familiar surroundings. In many cases, delirium and dementia are diagnosed clinically based on a patient's symptoms, but in some cases a test called an EEG is used. An EEG is an electroencephalogram. It involves placing electrodes on the skull, like what's shown in the picture here, and the EEG will record voltage changes in the brain based on electrical activity. In many ways, this is similar to an EKG in the heart. The EKG records electrical activity in the myocardium. The EEG records electrical activity in the brain. And just like in the heart, there are different leads for different anatomic areas. So there are different leads that examine the electrical activity in the frontal lobe, the parietal lobe, the occipital lobe, and other parts of the brain. And there are characteristic patterns of EEG abnormalities that you can see in certain neurologic diseases. But for our purposes here today, what you should know is that the EEG is usually normal in patients with dementia. It's usually abnormal in patients who have delirium. A very common finding in patients with delirium is diffuse slowing of the electrical activity in the brain detected by EEG. There are other findings as well that can be seen, but in general, usually the results are abnormal from an EEG in a patient who has delirium. So if you're on one of your clinical rotations and a medical patient is delirious at night, how are you going to treat that? Well, the first thing you want to do is fix the underlying cause. So if they're delirious because they're withdrawing or because they're infected, you need to treat that. If they're hypoxic, you have to fix their low oxygen levels. Patients who are in pain can become delirious, and if you treat the pain, they will get better. And patients that are dehydrated can also get delirious. So you want to take care of all these sort of routine things to make sure the patient's not delirious from some quick reversible cause. You want to put them in a calm, quiet environment, so noisy hospital wards are not helpful for delirious patients. And then finally, if they continue to be agitated and delirious and confused, we sometimes use drugs. And the most commonly used drug to treat delirium is haloperidol. It's often called vitamin H by house staff. So haloperidol is in a class of drugs called neuroleptics, and these are drugs that treat confusion and mania. The first one developed was chlorpromazine. So prior to the development of this drug in the 1950s, patients who had schizophrenia were often institutionalized and restrained and sometimes subjected to lobotomies to try and eliminate their agitated behavior. When chlorpromazine came along, this was the first drug that could actually calm patients with severe schizophrenia down, and it led to a lot of reduction in use of restraints, and it led to a lot of drug development, and subsequently some of these other drugs were developed, and now haloperidol is one of the main ones that we still use today. So the main effect of haloperidol and these neuroleptics is to block central nervous system dopamine receptors. Now they also block acetylcholine and alpha and histamine receptors, and we'll talk about this later, but this is responsible for a lot of the side effects. And drugs like this are used in schizophrenia and psychosis and mania, and then we use them in the hospital to treat acute delirium. So we break them down into the so-called high-potency agents and the low-potency agents. The high-potency agents are haloperidol, trifluoroperazine, and flufenazine, and these have many neurological side effects, and they also have something called extrapyramidal side effects, which we'll talk about in a minute. The other two agents, like thioridazine and chlorpromazine, we don't use that much anymore, but these have fewer of the neurological and extrapyramidal side effects. They have more than non-neurological side effects, and we'll talk about those in a minute. So what do we mean when we say that a drug has an extrapyramidal side effect? Well, the pyramidal system is basically the corticospinal tract. This is your motor system of your body. It runs in the pyramids of the medulla. That's how it gets its name. And damage to this system leads to weakness. The extrapyramidal system is associated with the basal ganglia and its associated tracts, and it modifies movement. These are tracts like the rubrospinal tract and the tectospinal tract. They all modulate movement. And so when you have damage to the extrapyramidal system, you get movement disorders. It's not so much paralysis like with the pyramidal system, but it's difficulty coordinating movements, or it's movement that you don't want. So Haldol has a number of extrapyramidal side effects, and the exact mechanism of these side effects is not known. It's believed to be a response to dopamine blockade in the central nervous system. And there are 4 movement side effects or extrapyramidal side effects of Haldol that you should know about: dystonia, akathisia, bradykinesia, and tardive dyskinesia. And I've listed them here in the order in which they occur. So dystonia is an acute effect a few hours after you give the drug. Tardive dyskinesia occurs after being on drugs for years. The word tardive means late. That's an easy way to remember that. And akathisia and bradykinesia occur in the middle. We'll talk about their time frame in a minute. So dystonia is an acute reaction to a dose of haloperidol. It occurs usually within hours or maybe days. It's an involuntary contraction of muscles. I think of it as a muscle spasm, or some people describe it as stiffness in the muscles. And you can treat it with an anticholinergic medication called benztropine. Akathisia is something that occurs after being on haloperidol for several days. It's basically restlessness, or some people describe it as an urge to move. It can be misdiagnosed as worsening agitation, and you can treat this by lowering the dose of haloperidol or using benzos, or sometimes people use the beta blocker propranolol. Bradykinesia occurs after you've been on haloperidol for several weeks, and it's basically Parkinsonism. It's drug-induced Parkinsonism, slow movements, difficulty initiating movements, and this also can be treated with benztropine. And then tardive dyskinesia is something that's rarely seen in the modern era, but it used to happen a long time ago when people took drugs like Haldol for years on end, and it's an irreversible condition where patients get chorea, which are those snake-like abnormal movements. They will smack their lips and grimace, and like I said, it's irreversible. Stopping the drug usually doesn't help. Once patients have developed tardive dyskinesia, they will usually have it for life. So for your boards, it's important to remember which of the neuroleptics cause these extrapyramidal side effects. It's much more common with the high-potency drugs, especially haloperidol, and this is why we don't give these drugs usually for weeks and months on end. They'll be given acutely for delirium, but then not anymore. They're less common with the low-potency drugs like thioridazine and chlorpromazine. Haloperidol has some other side effects you should know about. So since it blocks the dopamine receptors, this can cause hyperprolactinemia and galactorrhea. Since it blocks acetylcholine, muscarinic receptors, patients taking haloperidol get a dry mouth and sometimes they become constipated. The blockade of alpha receptors can lead to hypotension, and the histamine blockade can cause sedation. And then Haldol will prolong the QT interval in the EKG. It's one of many drugs that can cause QT prolongation and torsade de Pointes, the arrhythmia that can be deadly. And all these side effects can occur with haloperidol, but they are more common with the low-potency neuroleptics like thioridazine and chlorpromazine. Another special side effect of haloperidol and neuroleptics is the neuroleptic malignant syndrome, which is called NMS. This is a very rare but very dangerous reaction to these drugs. And an easy way to remember it is that it's very similar to malignant hyperthermia, which is a rare reaction to halothane and succinylcholine, and in fact it has the same treatment as that condition, which is dantrolene, a muscle relaxant. So NMS is a side effect that usually occurs 7 to 10 days after treatment with Haldol. So what happens to patients with NMS is they get fever and rigid muscles, and if you see fever and rigid muscles in a board question stem in a patient on a neuroleptic, this is the first thing you should think of. They also develop mental status changes. They get an encephalopathy. They get hypertensive and tachycardic from autonomic instability. Their CK levels will become very high, and this can cause myoglobinuria and acute renal failure from rhabdomyolysis. So what you want to watch is for fever, rigidity, and confusion after a dose of Haldol. The treatment is dantrolene, which is a muscle relaxant, and you can also use bromocriptine, which is a dopamine agonist. So now we're going to talk about dementia, which in contrast to delirium is a gradual decline in cognition. There's usually no change in the level of consciousness. It's usually all about cognition and cognitive effects. We'll talk more about that in a minute. It's usually irreversible, unlike delirium, which you can often make go away. It involves memory deficits, impaired judgment, and sometimes personality changes. So the classic triad of dementia is aphasia, apraxia, and agnosia. And if you know anyone who has Alzheimer's disease, you probably have seen all of these things. So aphasia is inability to communicate effectively. These patients will forget words. They can't understand what you're saying sometimes. They may nod to pretend, but they are not comprehending what you are saying. If you know anyone in your family or if you've ever met anyone with severe Alzheimer's, they do not understand what you are saying to them. Patients have apraxia, which is an inability to do pre-programmed motor tasks, so they can't do their job. So people with Alzheimer's can't function around the house. They can't do activities of daily living like cook for themselves and get to the bathroom. When the Alzheimer's gets severe, some patients can't chew, swallow, or walk. And then they also have agnosia. This is the inability to correctly interpret senses. So people who have severe dementia won't recognize their friends or even their family. A lot of times they can't interpret a full bladder, so they will urinate on themselves, and they can't interpret pain correctly, so they'll get agitated when they feel pain. Clinically, we assess patients with dementia using something called the mini mental status exam. So this is a series of questions you ask, and they get points for each correct answer. And more than 27 points out of 30 is considered normal. So just to give you some examples of some of the questions in the mini mental status exam, you check to see if they're oriented at time and place. You give them 3 objects and see if they can remember them and repeat them back to you. You will ask them to count from 100 backwards by 7s or to spell the word world backwards. You'll ask them to name an object you point out to them. This is testing for agnosia. You will ask them to repeat a phrase, and sometimes you'll ask them to draw an object that you show to them. And all these are parts of the mini mental status exam, and patients with dementia will have scores under 27 out of 30. So let's talk about the causes of dementia. Far and away the most common is Alzheimer's disease. This is about 60% of cases. After Alzheimer's, it's multi-infarct dementia, which is basically a series of small strokes that results in dementia. Third most common cause is Lewy body dementia, which we'll talk about in this module. After these 3, everything else is very, very rare. There's something called Pick's disease, which we'll talk about in a little bit, that can cause dementia. Normal pressure hydrocephalus can cause dementia. Creutzfeldt-Jakob disease, which we'll talk about later, can cause dementia. You can also get dementia from advanced HIV, certain vitamin deficiencies, and then from Wilson's disease as well. So Alzheimer's disease is the most common cause of dementia, and it is degeneration of the cortex. So contrast this with the basal ganglia that degenerates in movement disorders. When you get degeneration of the basal ganglia, you usually get unwanted movement like Parkinson's and Huntington's disease. When you get degeneration of the cortex, you get dementia. This is a generalized degeneration of the cortex, so it usually doesn't cause focal deficits. It causes a global loss in cognitive ability. The hallmark of this condition from a neurotransmitter perspective is loss of acetylcholine cortical activity. There's a deficiency of choline acetyltransferase in patients who have dementia, and this is very prominent in places where acetylcholine is important, like the basal nucleus of Meynert and the hippocampus. It's high yield for your boards to know a little bit about the Alzheimer's biochemistry. So there's a protein called amyloid precursor protein, which is normally found on neurons. And it usually gets broken down into an alpha degradation product that doesn't go on to cause any problems. But sometimes, for reasons we don't understand, it gets broken down into a beta product. And this beta breakdown product can form alpha-beta sheets of amyloid, which can build up in the brain and cause Alzheimer's. Now, a lot of research has gone into which genes put patients most at risk for Alzheimer's. And you should know that there is an epsilon 4 allele of the apolipoprotein E molecule that increases the likelihood that amyloid precursor protein will become the beta breakdown product and cause Alzheimer's disease. There's also an epsilon 2 allele of that same apolipoprotein E, which is protective. It makes it less likely that the beta breakdown product will form and that you'll go on to develop Alzheimer's. So just a word about amyloid in general. These are proteins that are found in many different diseases, and they build up in the extracellular space. They all stain with Congo red, and they all have apple green birefringence when you look at them under polarized light. The disease process depends on where they are found, so you can get amyloid heart disease and amyloid kidney disease, but when amyloid builds up in the brain, that's when you get Alzheimer's disease. The most important risk factor for Alzheimer's is age. Alzheimer's is largely a disease of the elderly. Most cases are considered sporadic, meaning that they are not caused by a mutated gene that is passed through families. There are a couple of situations where patients can develop Alzheimer's at a younger age. One of the most important is the Down syndrome. As you may know, children born with Down syndrome have 3 copies of chromosome 21, and the APP gene is found on chromosome 21. Therefore, it should make sense to you that children born with Down syndrome can develop Alzheimer's and can develop it at an early age. In fact, most children born with Down syndrome will develop Alzheimer's by the time they reach their 40s. There are also rare familial forms of Alzheimer's. These are in contrast to the usual sporadic forms. These are passed down through families due to gene mutations, usually caused by a mutation of genes called presenilin genes. There are 2 of these, presenilin 1 and 2, and they've been found to be mutated in cases of familial Alzheimer's disease. Patients with Alzheimer's get atrophy of their cortex, so this means that the gyri of the brain narrow and the sulci widen. So let's look over here on the right. This is a patient with severe Alzheimer's disease. So these sulci, these spaces between the tufts of brain, get wider and the gyri get narrower as compared to somebody with a healthy brain. They also get what's called hydrocephalus ex vacuo. This means that the ventricles appear larger on CT and MRI imaging, and it's not that the ventricles are getting larger, it's that the cortex is getting smaller. Let's talk about the pathology of Alzheimer's disease. You can see beta amyloid plaques on microscopy, and this is an example of what one looks like here. And you also see characteristic findings called neurofibrillary tangles. So what are those? Well, those are a collection of tau protein inside the neuron cell body. So this is a normal neuron cell body here and another one here. But this one down here has this dark purple material right here, and that's that hyperphosphorylated tau protein forming a neurofibrillary tangle that you see in Alzheimer's disease. The symptoms of Alzheimer's come on slowly and insidiously, and most patients do not notice them. A classic board presentation is for the patient to be brought in by a family member who says they're getting more forgetful, but the patient themselves does not notice this. We diagnose it clinically, you can confirm it by autopsy, but there really is no imaging or blood test to prove someone has Alzheimer's disease. There aren't really very effective treatments for Alzheimer's, but some drugs have been shown to have limited benefit. One of these is memantine. It's an NMDA receptor blocker. NMDA stands for N-methyl D-aspartate. It's a glutamate receptor, and this drug has some limited benefit in Alzheimer's. It's got some non-specific side effects like dizziness and confusion, and some patients have hallucinations. And then there are some acetylcholinesterase inhibitors which have been tried to boost the acetylcholine levels in the brain. These are drugs like donepezil and galantamine and rivastigmine, and these also have some non-specific side effects like nausea and dizziness and insomnia. And then there's some evidence that vitamin E may help by protecting against oxidation. Multi-infarct dementia is the second most common cause of dementia. It's dementia after patients have multiple small strokes. Patients who get this usually have vascular risk factors like high blood pressure and high cholesterol and smoking. They may have other evidence of vascular disease like coronary disease or peripheral vascular disease. And the key thing here, especially for your boards, is this will be a stepwise progression of symptoms. So patients will be doing okay cognitively and then have a sudden change and then another sudden change. And that's because they're having little strokes that make them worse each time. The only treatment for this is to make the risk factors better. You can't treat the dementia itself. A Lewy body is a collection of a protein called alpha-synuclein, and when it builds up in the brain, it can cause dementia or Parkinson's. When it builds up in the basal ganglia, it gives people Parkinson's, but when it builds up in the cortex, it gives people Lewy body dementia. And the triad of Lewy body dementia is dementia plus Parkinson's symptoms plus hallucinations. Now, patients who have Parkinson's can develop dementia as a late finding in the disease, but when they get Parkinson's symptoms first and then dementia later, that's Parkinson's disease. When they get dementia first and then get Parkinson's symptoms, that's Lewy body dementia. So that's how you tell the two apart. And the hallmark pathologically is this Lewy body, which is this round purple thing that you see under the microscope. Pick's disease is a very rare cause of dementia. It's called frontotemporal dementia. So you get frontal lobe changes and temporal lobe changes. So what are those going to be? Well, frontal lobe changes are changes in personality and behavior, and temporal lobe changes are aphasia. And pathologically, there are these characteristic findings called Pick bodies, which are spherical tau proteins. So they have a similar appearance to those neurofibrillary tangles, but they're in nice round circles as opposed to the abnormal shape you see in Alzheimer's disease. Creutzfeldt-Jakob disease is another very rare form of dementia. It's called a spongiform encephalopathy because when you look under the microscope, you see these round spongy vacuoles in the brain. It's caused by an abnormal protein called a prion, and this is a protein that can cause damage to the brain and that can reproduce itself. We'll talk about that in a minute. Now, how do you get this abnormal protein? Well, it's commonly from a sporadic mutation, but there are some familial forms, and then people can get it transmitted. So if they touch an infected patient's tissues, they can get the protein in their own body. And then this is also the same thing that causes mad cow disease. So when mad cow disease was a problem in the 90s, people were very afraid to eat beef because they thought they might get this prion inside their body. So the proteins that form prions are called PRPC, and they're normal. We all have them in their body, and they're like these green molecules I've drawn up here. The problem is that if one of the abnormal prion proteins, which are called PRPSC, gets into the body, it can link up with a normal one and convert the normal one into an abnormal. So basically it can duplicate itself. So you start with one red, it links up with a green and forms two red. And this process can go in a vicious cycle, and you can get big beta-pleated sheets of these abnormal prion proteins. And keep in mind, this is just a protein, but it can duplicate itself. So this is flirting with the border of whether it's alive or not alive. Some people say this is like a protein that's got characteristics of being a living organism because it can reproduce itself. But the scary part is once you come in contact with this abnormal protein prion, it can start converting all the normal ones in your body to abnormal ones. Creutzfeldt-Jakob is a rapidly progressive dementia, and the key word is rapid. Most patients who get dementia develop it over months or years, but these patients will develop it within a few weeks, and that's how you can recognize it in a board question. It's very serious. Luckily, it's very rare, but it's serious and usually die within a year from Creutzfeldt-Jakob. The classic features include ataxia, so these patients will have falls and lack of balance. They have something called startle myoclonus, where they startle to minimal or trivial stimuli. And then there's a characteristic finding on EEG testing called spike wave complexes, and it's high yield to remember that. The gold standard for diagnosis is a brain biopsy, but this is rarely done. There are clinical criteria that are often used to diagnose the condition. And that concludes our module on delirium and dementia.